you know that there are over 700,000 knee replacements that are performed every year? There are over 400,000 hip replacements that are performed every year. That's a lot of hips and a lot of knees. That means it must be raining hips. It's raining hips. It's raining hips and knees everywhere. So if that's the case, that means if you're watching this video, you probably will need a joint replacement. Probably need a hip replacement. Probably will need a knee replacement. So what we decided to do, one of my good friends, Dr. Adam Wright, decided to sit down and do a podcast and talk about the process of taking someone from when they are considering a knee replacement all the way through to surgery and then post-op. So if you're having a lot of pain right now and you can't get up and you're struggling, you may want to watch this video. And if it's the pain in your knees and your hips, you may want to watch this video. If you have a loved one that's in a lot of pain, you probably need to watch this video too. And it'll help you. I think it'll help you basically have a good understanding, a very high level understanding of what to expect when you're going into surgery way before you need it. We'll do a lot of series of videos like this with Dr. Wright, and I hope this helps you. This is a video with Dr. Wright and Nick Berger, who is a medical sales rep, a device sales rep, who works hand in hand with Dr. Wright to perform this surgery and to make sure everything is smooth. Stay tuned. Let's watch this video. You guys enjoy. Walk me through the situation, example of there's a lady with a right knee replacement that's coming in. Walk me through what happens on your end and then on your end.
Yeah. Somebody comes in, say tomorrow. I've got 25 or so people I'm seeing tomorrow. It's just medium day. Someone comes in, I guess the ideal candidate for me to see in the office is somebody who's 60, 70, they've had knee pain for a while, and they've tried things, right? So they've tried what I call the easy stuff, anti-inflammatories, physical therapy, weight loss, injections, and they've done conservative treatments, right? We don't want to start with surgery. Every once in a while we do if somebody comes to just a very bad problem and there's not much else to do, but we like to try and prevent surgery until we realize that's what we got to do. Yep. And so if they show up and they've done all that, then we're ready to go. And so we say, hey, let's talk about what you have, what the treatment options are, and I kind of like to present like a menu. We've got this. You tell me what's palatable for you. Which of these have you tried? Which do you like? Which do you not like? What works for your lifestyle? Because some people say, well, physical therapy, I'm sure that's great, but I don't have time for that. I work at a job, or I'm scared to go out of the house. There's all sorts of reasons. And then once we finally say, okay, let's go for surgery, then we have to look, okay, are you healthy enough? Are there things that would maybe give us a bad outcome? Do you have diabetes that's not controlled? Do we need to stop smoking? Or do you have Hep C that we can treat? There's all sorts of things that we look into to say, okay, we've decided this is what we want to do. What are the traps? Let's make sure we avoid those. And then let's get it rolling. And so go to the hospital, get all the workup that you need, CT scans, everything. See your primary care doctor, or cardiologist. Come back to me.
All that insurance.
Yeah, that's a whole other
Golly.
And shockingly, I know so little about that because there are people that know more about that than me. And we employ those people to say, make sure that this is all approved and all the paperwork's handled. And they come back to me, and then we discuss the surgery, what we're going to do, all the medicines people get, and that takes about 45 minutes. Okay. And then we actually show up, right? So my day on surgery days, I typically get up between 5 and 5:30, and go work out or get some breakfast, and hang out at the house for a little while, and then go to the surgery, go to the hospital where we're doing it at. Usually get there if cases starting at 7, about 6:30 or so. I go in scrubs, but then I usually change into specific operating room scrubs that only stay at the hospital and that are laundered by the hospital, so they're as clean as possible. And everything's about creating a clean environment. And then I go talk to the patient. We decided we were still going to do the left knee, just like we decided. They tell me it's the left knee. I
Make
check
sure
everything.
is it the right one?
Yeah, exactly.
Is it
And then I write my initials in the left knee, and then I say, okay, let's go. And at that point, I usually run over to the operating room, check in with Nick, who's been there for a while, and get everything else ready.
Yeah.
Make sure we're all good to go. And then I either say, well, what do we need to do to get ready? What else can I do? I usually have paperwork to do. I'm on several committees, and so I'll go and talk to representatives of that to do my other business while they're making sure everything's good to go. Then the anesthesiologist comes in and they do their part, do their blocks, go through last kind of checklist before takeoff, if you will, and then we go to the room.
Wow. So while you're getting, let's pan over to you. What happens on your end?
Yeah. So if he signs somebody up, we usually get an email a week before or a couple weeks before from a scheduler showing left knee, Diane, and
Diane's a good name.
Diane, yeah.
I like that.
And we check in with radiology, with imaging to make sure they have the CT scan, because Dr. Wright uses a CT-based robot. And for that, we need to have the images done by a certain protocol so that we can segment them and get a digital image of the implants and overlay those onto the patient's anatomy. So in order to do that, we need a lot of stuff to be done beforehand. So going into the case, we've got that digital image, we've got the CT scan, and when we're in the case, he's able to mirror those together and overlay them so that we get precise surgery.
By far, there are more hours that go into preparing each individual case surgery than it takes to actually do it.
Wow.
To just
every meticulous.
Yeah. And now I have to give a shout out to my partners that do this. That I don't specifically do the segmentation, but it can take 30 minutes to an hour per patient just to get the CT scan where it needs to be so that we can see it. See the digital image of those implants. So
of the 3 knee replacements I did today, the longest one was 45 minutes.
Yeah.
Wow.
45-minute case, like 1 hour of pre-work just to get the images. Ready. So it's very important to have that information because it makes his job a lot easier. Because of that, we can see where the osteophytes are, where the defects are, exactly where the implant's going to sit. So we have a lot more information going into it so that there's less outliers and less issues that could arise. But that's, days, weeks before. A couple days before, I get into that app, I order the implants. I know exactly what side it's going to be, male or female. I know what size now because I have the digital image of everything, so I have an idea of what implants to go to get there.
We have a planning meeting too.
Yeah.
Oh wow. Okay.
Yeah, my partner
once
Kim,
or twice a week.
That's cool. Prior to.
Yeah. We'll go over those images and a pre-plan based on how the patient's presenting, varus valgus, flexion contracture, if it might need to be a constrained implant, something like that. Anything out of the ordinary, it's brought up in that meeting. Then we know to order something special to get it there. Day of, for a 7:00 case, we have to be there at least 1 hour before. So 5:50, 5:55, 6:00, we're there in the OR trying to pull the trays, making sure that they're processed from, the day or days before, to make sure that we're good to go. So that if there is any issues, we have time to be able to fix those. Check implants, make sure all the sizes and sides are there that are needed. Bring those into to the room, get the room set up, make sure the drapes are there, make sure the robot's pulled in, staff's happy, and then doc comes in. So it's just kind of prepping everybody, getting everything there, and making sure there's no surprises.
Yeah. So now we got Diane that's ready, right?
Ready.
On coming in, walk us through that process when Diane is there and you're maybe talking to her for the final go around before she's put under. Walk us through that.
Well, there's all sorts of different levels of involvement that the surgeon can have depending on the day and the team that you have. Now I kind of just try and stand back a little bit because
Nice.
everybody knows what they're doing. And if I show up and I'm there and just kind of peering in the door, like it can make some people nervous, you know? And so, right, you know, and it's looking like, why is he looking
Did I do something wrong?
And when you first start and you're getting to know your team, you do that because you want to make sure that they know what's going on.
Yeah.
But my team knows what's going on, and I know he knows what's going on. He's in there with everybody. And so I tried to do as little micromanaging as possible.
Nice.
Because that just nobody feels good with that. You know, so like I said, I go and do other things that I need to do. I talked to the patient. We said, okay, here's the medicines we're doing. Here's what's special for you. Here were our concerns before surgery. You remember that. You remember what we're worried about. You remember what you're going to do differently than we might for other people. Okay, do you feel like you're going home today or tomorrow? Or some people have a preference strongly one way or another. I say most of my patients go home the day of surgery, but some people are like, well, no, my daughter's actually not flying in until later tonight, so we'll just do tomorrow or things like that. So then they roll in. They are, talking to the anesthesiologist. They usually give them some happy juice at that point, so they're a little goofy, which is always fun. All the silly things people will say. Some people
that's a whole nother podcast.
Yeah, I know. Right. Some people will request certain songs for when they pull into the OR, which is fun too.
Wow.
We like to accommodate that whenever we can.
That's cool.
The walkout jam.
Yeah,
that's
exactly.
Pretty cool.
And I think those people, they always wake up very well. People who come in a little excited.
Yeah, they're mentally ready.
And there's a lot to that about what
mentality.
Yeah, what music you listen to or kind of how you are. The anesthesiologist will tell you, hey, don't say anything that might scare somebody. Don't listen to rock music all crazy unless they like that right before they fall asleep, because if they go to sleep anxious, they'll come up that way. And I think that your stress hormones play a lot into that too. Cool. So get them in, make sure they're calm, slowly induce anesthesia, which is it's a countdown, and then you go to sleep. And then that's as soon as they're out, the anesthesiologist will give us a nod or a thumbs up or say, go. And then it's action. It's a coordinated dance from that point. Wow. And everybody's kind of got their role. Soon everyone knows, what they're doing because they've worked together. And it's, hey, let's get, if it's a knee, it's get the tourniquet on, get the leg all, it's like a sterile trash bag in a way where it's just what you need to see is exposed. There's certain leg holding devices that you prepare and get ready. And then it's get all sterilized and go. And everybody puts on their sterile shirt, as I call it, gown and gloves and a bucket over your head that you can see through to keep blood and guts out of my face.
No guts.
Yeah, no guts. Yeah,
I'll be back.
Yeah, we're done with that. And then we all go.
Wow. How many people are actually in the room? And like, if you were to walk through, like, this person does this, if you could break down for everyone, like, what
people are really surprised. Yeah. I think they think it's going to be me and the anesthesiologist and nurse and my PA, right? And those people are there, me, anesthesiologist, those are the two doctors in the room. The circulating nurse, who is in charge of, when you say, hey, we need this, can you go grab that from this? Or, making sure the consents and everything are right. They're functioning as leading the timeout process. They're the nurse, you need them. Yeah. And then there is, my PA, my physician's assistant, who's helping me out. I only have two hands. It takes about 6 to do one of these procedures, right? So then there's the scrub tech, who, when I say knife and I put my hand back there, or scalpel, they're the ones that put it in my hand. The goal is I'm taking care of the patient. I should never not be looking at the patient. So I always ask for something, just put my hand back there, and they put it in my hand. Not upside down, not backwards, the right way.
The right way, hey!
Yeah. And when I work with the same team, I don't even call for instruments anymore. I just put my hand behind me, and I can even just feel that's the right one, cool. And I go for it.
That's cool.
They have it ready, like they're looking at me, waiting for me to put my hand back. I don't even have to tell them what I need anymore.
Man, that's awesome.
So scrub tech. There's usually what we call a leg holder, which is a second scrub tech. So they are just as skilled as the person and that's handing something to me. And so usually if I have, one room that I'm operating in, those two scrub techs will alternate, because the leg holder position is kind of an athletic position depending on the size of the leg. And it sounds very unskilled to be a leg holder. It is very skilled. Yeah. If you are doing it well, it makes a surgeon's life a whole lot easier and a lot safer surgery for the patient. Wow. So those are all the people, me, my PA, 2 scrub techs. Those are the ones who are actually touching the patient.
Okay.
Then there's the device rep for what we're doing, the person who knows the product, who knows the ins and outs of everything that we're doing, which is Nick. And they are there for when I'm using the Mako robot. There's what's called the MPS, the Mako product specialist. Their whole job is to know everything, the ins and outs of this fantastic machine and how it works and what are we doing with this and what are the tolerances for each device and what we're trying to accomplish here. That's the basic set of people. Most of the time when you're in a good environment, you're also in a teaching environment. So there might be another scrub tech who's learning. There might be a nurse who's learning. There might be a trainee from the implant side of things, or a medical student or a resident. Now, where I'm at, we don't have medical students or residents, but we're teaching people in nursing school. Right. And sometimes people come in to observe surgery, and sometimes they're government administrators making sure, hey, everything is as safe as it can be. Right. There's also anesthesiology assistants that are coming in and out, respiratory technicians. Right. Depending on the surgery, you'll have a radiology technician. So a huge portable x-ray machine that can rotate around the patient. Well, somebody's got to work that, and so all these other people are optional, if you will, depending on what you need, what the patient needs, and what you're trying to accomplish.
Yeah. It's amazing because it's everyone coming together for a big masterpiece.
Yeah.
Right? And everyone has a part to play, just like an orchestra. Mm-hmm. And making sure that everyone's doing their job. And I love what Nick said is, okay, like, is everyone the morale of the room? Is everyone's morale good?
Yeah.
Right. If it isn't, then you can get a little dicey.
You're right. Exactly. Yeah. If there are personality issues, it can be a problem. Wow. When a surgery goes well, it feels awesome. And because you did a great job and you the patient's going to be happy, but as you're doing it, it feels like it's a coordinated effort. And so no matter what your background, you've been through that, whether it's a musical where everybody knows their lines or a play, or whether it's a football play where your route and you're running it and as soon as you turn on the ball, it's going to be in your hands, or whether it's a song that you play, and like, hey, my guitar solo is coming up, and this is going to be great, and then I'm going to fade to black, and then lead singer's going to take over. Like, all of us in each aspect of our life have experienced something like that. Yeah. And when surgery goes well, and it feels like all those things combined all at once.
Yeah. What are from your aspect? What would you say that is the biggest piece to make sure that everything is executed as well on the device side, on making sure everything is appropriately done? What would you say is the biggest piece?
The first thing I thought about is the personality and your relationship with the doctor. It was the doctor's relationship with everybody in the room. So their personality it sets the tone for everyone. Some all sorts of personalities.
Yeah.
I'll just say.
Yeah.
So
all types.
It to be a people person and good with your hands. He was speaking earlier about having that science background, but also loving history and being able to speak to people and understand and want to ask questions and listen.
Yeah.
In those situations, more times than not, of course, you're going to have a better case. Yeah. The staff's going to want to help as much as possible because they love working with happy people.
Soft skills.
So I think that is going to lead to, ultimately the best situation. Awesome. There's plenty of times when that has to be overlooked because that will never happen for certain docs. Honestly, that's just how it is. They can be absolutely fantastic with their hands, know exactly what they need to do in that surgery, and that's why they do what they do, and we all appreciate that. But we're not looking to be best friends. Sometimes, you just gotta know who you're working with, and some don't like music at all. Some like rap, some like country. You gotta understand who you're working with, and if you can do that, get on their page, same wavelength, then everything's gonna be great.
That's awesome.
Either way.
Right.
Even the music analogy is good.
Yeah, that'd be funny if you love rock and he loved country, and it just didn't make it's just if you let those small things get in the way, it just messes up the whole thing. That's crazy.
Not one person can do everything.
Yeah.
If you, in any situation, at home, you've got a wife and family that support you. You can't do it all without that.
Yeah.
Teamwork on each side. You've got your PA and your staff. You've got your staff. I've got my team, my MPSs, my partners, my operations team. Everybody's working in their own orchestra.
Yeah.
But it all comes together.
If you like this video, please like and subscribe. Join our YouTube family. And then also every Sunday, we're airing a podcast consistently around 5 o'clock. So if you're not doing anything, hop on and watch it. It's regarding healthcare at home. It's regarding healthcare industry. It's just great information, and you'll laugh a little bit. So feel free to hop on and watch that. Like and subscribe. We'll see you next time.